So Helen's originally from the UK. She has a clinical, managerial and academic career in healthcare, which spans over 30 years. She moved from the UK in early 2014 to work at Midlands Health Network, where she's leading the implementation of a new model of primary care across their general practice network, and just brings a very different lens to the issue of delivering universal services. Thank you, Helen.
I have my chairperson's stress relieving app here, because what this will do is flash when I need to finish, give me 5 minutes notice. And I can telepathically receive from Jane that she's saying, please cut 10 minutes off your presentation, because we're already running a little bit late. Kia ora, and thank you very much for inviting me. Inviting me. I'm here from my own free will to speak at the conference. I generally speak to, and have done for the past 10 or so years, to really groups of GPs. So this is a very refreshing change of audience, although if you've read my bio, you know that I have managed sexual health services before. I use the term manage loosely, and you'll see why in a moment. I'm really looking forward to embarrassing my children on Facebook tonight by putting on that I went to my first sexual health conference, and the chair opened up by talking about loving your condom. So, challenging the status quo. Why do we need to challenge the status quo? Well, I would argue, with my academic hat on, you'll see that I wear as Jane said, I wear 3 different hats, and I use them interchangeably depending who the audience is and what I'm about to say. With my academic hat on, I'd say we need to challenge the status quo, because generally, and I do generalise here, health services are organised and delivered more by historical accident than by intelligent design. And I'm going to talk a little bit later about what I mean by intelligent design, and that's not the creation evolutionist theory, but about how we ensure we're delivering really coherent services. You know, just the title, universal, world-leading services. Wow, that's a big ambition, isn't it? Particularly when countries like China and Japan are really overtaking countries like the UK in terms of how they deliver services and how they use technology and how they care for their older people. Back in the UK, we're a little bit arrogant that we think that we are world leading, and perhaps we were during the Commonwealth times and when we occupied a few countries, but we're definitely not world leading in quite a few services now, and places like Asia are overtaking us. So when we talk about universal world leading services, we have to be really careful about who we're benchmarking ourselves against, and also world leading from whose perspective? World leading from the minister's perspective, world leading from us who are involved in the delivery of healthcare perspective, and I would argue that most health services, their historical accident design is delivered to make our lives as health providers a little bit easier, or world leading from the children and adults that use sexual health services, because that world leading term could mean very different things, couldn't it? And of course, there's a lot of challenging the status quo about. I mean, I've spent the last 10 years helping organisations and systems, and when I say systems, I mean systems actually like yours, the sexual health services across New Zealand, which I think are some of the most complex services to deliver and have an intelligent design underpinning them, not because you're within sexual health, although obviously you've got some cultural sensitivities around that, but because you are a network of not just state provision, but voluntary provision, NGO provision, a lot of specialist services, a lot of generalist services, and actually getting intelligent design that brings all that together is much more complex than, for example, some of the work I'm really involved in, which is about challenging the status quo within a general practice. It's much more complex, but it's still doable. But there's a lot of challenge about, and I'm particularly involved in some of the work that you see on the screen about looking at actually how much of the way those services are delivered and integrate with each other is by accident or design. And technology is a really interesting one, isn't it? Because we do need, in the healthcare sector particularly, need to challenge ourselves about our use of technology. Compared to other sectors in the world, and I'd so argue about in New Zealand too, we are lagging behind in the way that we use technology. For example, we can do a lot of, we can do a lot of our day-to-day living on one of these. We can do a lot of our day-to-day living using an app. And some people, and even apps are sort of getting a little bit outdated now in terms of technology. And some people challenge me by saying, well, actually, yes, that's okay if you're not from a poorer family and you haven't got phones. But actually, you can give someone a phone for $10, and actually you can download software, which means that they could access their patient records, they could receive text reminders for their appointment, and make bookings online without it actually costing them a thing. Now, $10 is a lot cheaper than an appointment where somebody didn't turn up. So we really have to challenge ourselves about the way we think about technology. We also need to challenge the status quo in terms of the funding models. So there isn't a whole lot of point in doing lots of redesign about how the way health services are organised and the way they're delivered if we then try and fit that into an old funding model. And I'm more than conscious here about some of the differences between the UK and other countries, and here where you have the co-payment system, which adds an additional complexity into redesigning services, particularly if you're wanting to keep patients, for example, away from general practice who don't need to use it, so that you increase the capacity for those that do, increasing access. And of course, probably one of the biggest challenges when you're looking at creating intelligent design and redesigning services, that we are our biggest enemies. So actually, if you start to do some work around organising and delivering services that have been really, really well thought through in terms of how would you want them to be delivered, sometimes you can start creating a revolution, because organising services and developing services by evolution and just tweaking bits around the system doesn't really change a lot. And actually, if you really get into the intelligent design work, you actually start creating a revolution. And actually, it's not generally the patients or the politicians actually who are not happy with the revolution, it's the people providing the services. So what do we mean by intelligent design? Well, I'd say we know if we've got intelligent design right if we can stand up and say that the changes that we want to make to the way that we coordinate services across the different providers and different organisations, and the way we want to change the actual service delivery to service users, we can articulate that there are the change is better for those service users that are using our service, that are using the services. And of course, I was really pleased to hear in the presentations this morning that I found really very interesting, that we can't just group people into one lot and say, well, it's got to be better for patients, because who are the patients? It's got to be better for Māori, because Māori want services provided in different ways too, depending whether they're young or depending whether they're old, depending whether they live in an urban community, depending whether they live in a rural community. So we have to be really clear that we can articulate that for all the people that use the services, that it's better. Otherwise, why do it? We have to be able to articulate very clearly that it's going to be better for the health system in terms of how we use the total resources. And also, we do have to be able to articulate really clearly that it's going to be better for the people that are providing the services, because obviously we do know from evidence that happy professionals deliver better quality services. So what do we mean by intelligent design? Well, in order to have a really well thought through redesign of services, it does need to be informed by data. And actually the presentations this morning have made my point for me, because I've been involved in quite a lot of service redesign initiatives where the redesign has been based on assumption and myth of the providers that deliver the service. And what the presenters showed us this morning, that actually some of the things that we assume, like abortion rates, like teenage pregnancy rates, actually when you look at the data, the picture is very different. So it does need to be informed by data. And it needs to have some coherent design principles, and I'll talk to you a little bit about that in a couple of minutes. It needs to be outcome focused, of course, and a lot of service redesign initiatives I've been involved in, what people tend to talk about is inputs and numbers and widgets, or outputs, and not really being able to clearly define or articulate the outcomes that they're looking to achieve. And of course it does need to be affordable, so it's no good coming up with an intelligent design which meets all those criteria, but actually we can't afford it. So here's just an example of what I mean about design principles, and I would argue, based on the evidence and also based on my empirical experience, that unless you do this bit of work as a system across New Zealand and within sexual health services, unless you do this sort of thinking about old and new design principles, it doesn't really matter what the policies say, and it doesn't really matter what the action plan is. You're likely to end at the wrong point. So just some of the examples around general practice, but I've also been doing this, some of this work here around community nursing too. If you stand back and look at the service you provide and say, actually, if I didn't know these services as well as I do know them, and I had to say, what were the design rules of the architect who designed the way our services coordinate or don't coordinate with each other, and what were when they were creating this system, what were the principles that they were used, and then say, actually, what are the principles, the design rules that we'd like to create? They're usually hugely different. But what you can do is take the new design rules and then start to shape the type of service that you want, and then that sort of informs your workforce plan, your funding plan, your premises plan, how generalists and specialists integrate and coordinate their work, whether you have a central reporting system, whether you don't. So this is just an example of some of the stuff we do in general practice, and I could talk about this I can talk for England anyway, but I can I could talk about this one slide for quite a long time, so I've summarised it quite a lot. But if you take the old design of primary care general practice, if I was looking at it and say, what did the architect of that system, what were their design rules, I would say that one of the design rules was that every patient coming into general practice would have exactly the same length of time in front of their GP or their nurse, irrespective of what their need was, whether it was a very quick need or whether they'd got huge, complex social and healthcare needs. We'll just give everybody the same time. Actually, what you'd say in creating your new design rules is you're going to give everyone an appointment for the length that they need. Now, of course, how you do that is then a different matter, and of course that's challenging in itself. But at least if you've got the core design principles right, then you know that when you're starting to go on to the how, at least you're basing your how on something that's coherent. I won't go through them all, but for example, face-to-face consultation in general practice, you'd have said, and I am generalising here because of course not all of them just do face-to-face, you would say that actually the architect of general practice was that everyone can only receive health care face-to-face, sitting in front of a GP or a nurse. Well, actually, in the new design rules, you'd say actually not everyone needs to do that. Actually, some patients can manage some of their healthcare through email. Some patients can manage their healthcare in front of with their GP and nurse over the telephone. Not everyone has to see face-to-face. So you start to create some more design principles. I think pertinently with sexual health type services too, and the types of client groups that you particularly work with, some of the design rules that you'd start to look at is actually in the old design rules we expect everyone to come to, generally speaking, a white middle class setting to receive their healthcare. That's certainly true for most of general practice. Actually, when you start to look at some of the new design rules, you can say, well, we could deliver this bit in the community, we could deliver more of this in the schools, we could deliver this here. We don't necessarily have to deliver this in a hospital or a state setting. So you get my point. So you start creating the new design rules, and I'd emphasise again that if you don't do this bit of work when looking to how to improve the system, then you miss out a really key point. And of course, this is what we end up with when we've gone through the design rules for general practice. What we've started to model, which actually is not dissimilar from the primary medical care home model in the States and other countries, is a completely different design of general practice. Completely different. It doesn't bear much relation to traditional general practice, but we know from the evidence that it delivers much better care, and we can articulate really well how it's better for different groups of patients, how it's better for staff working in the practice because they're not having to fit everybody into that universal model, and actually how it's better for the system. Of course, once you start looking at design rules and creating a completely new design rules, you have to start challenging historical custom and practice, particularly of the professionals that work in the services and the different professions that work in the different types of services, and also the custom and practice and behaviours of people that use the services, because they're used to services working in a different way, but particularly the people who work, fund and plan the services. And actually I took this photograph on Monday. I was in Christchurch in Canterbury. For those of you from Christchurch, you'll know the design lab that the DHB funded. It's a fantastic place where you can do a lot of this design work, and they'd got these suitcases by the door with the intention of saying, please leave your baggage at the door before you come in and start designing your design principles. So I quite like that. So now I'm going to put my academic hat on and give you a little bit of reality around redesigning health services in a way that are much more coordinated and much more coherent. And with apologies to our first speaker, actually what the evidence tells us is that whilst national policy and national strategy and even individual organisational strategies are good, and you can't argue against that, they only really tell us the what and the why, and actually they tend to have really weak follow-through. And I'm summarising the literature here, but actually quite a few studies have shown that 60 to 70% of national policy and national strategy is not implemented. And actually, I guess that would be my experience too, and probably some of yours too. So we have to ask ourselves, why is that? And actually, if we sit back as clinicians and service providers and say, well, our services are not going to get any better until the minister's sorted out his strategy or the government's delivered their strategy, then actually we're missing a real big trick. And one of the reasons for that is because there's a huge amount of evidence that says that the dependency factor in terms of actually delivering the change that we're looking for, depending on what our design principles are and how we want to articulate them, is actually more dependent on the attitude and will of the professionals working in the service than any political, structural or organisational levers that they can pull. And I know this from some of the evaluation work I did when I was in leading a health policy unit at the University of Birmingham, was that we evaluated a national strategy to move care out of hospitals and closer to home in the community. And some areas of the country were far more successful than other areas of the country, and yet they were working under the same political and structural and organisational policies of the day. And the big factor in the change of services and them making it better for patients was that the professionals that were working in that particular area had got a real will to make change happen. And of course, because of that, you know, if you're wanting to implement an action plan for sexual health services, we also know from the evidence that the action plan will just remain the action plan sitting on people's desks or sitting on their computers if there aren't the local service champions to own, lead and sell the change. And there's a huge amount of evidence to say that unless you have harnessed that and encouraged it and funded it in some way, to have those champions in the individual services around the country, your action plan is likely to stay and fall into the category of that 60 to 70% of strategy and policy that didn't get implemented. So my challenge to you working in those services is, how many of you see yourselves as being the local champions that will pick up an action plan, make it your own and lead it and sell it and make that change happen? And another reality check too is that most of the innovation that we've seen in healthcare around the world that has been sustainable and has survived changes in minister and changes in political parties is actually innovation that's been driven by the provider themselves. It isn't innovation that has come through from national policies and national strategies, which again is another reason to put the challenge out to the people actually working in the service to say, you need to own the change that you you want to see. Otherwise, the change is unlikely to happen. And of course, what you also need in order to follow that through is the absolutely bucket loads of professional engagement with those that you're expecting to make the change alongside you, but also user engagement from those different groups and those different cultures that use the services, because we know from the evidence too that without that the change is unlikely to be sustainable. Of course, that's easy for me to stand up and say. It's quite difficult to do, isn't it? Really good engagement is quite difficult to do, and it needs to be funded. And here's a little hobby horse of mine, is that often when we're looking at national strategies and national policies, and I hear providers speaking, what we tend to talk about is integration. We need more integration. We need to be more integrated. When actually I'm starting to develop the theory that we use the word integration when we know things need to be better, but we don't really know what better looks like. So we just say, well, we need to make sure the services are better integrated. And I come back to the design principles and say one way of really determining what better looks like, so we don't need to use the word integration so much, I think we've all become a little bit desensitised to it anyway, is if we get those design principles right, then actually we do know what better looks like, and we do know what we need to do in order to make better happen and for it to be sustainable. There's also a little bit of a myth too that integration saves money. And actually there isn't any evidence to support that whatsoever. In fact, there's a growing amount of evidence to suggest that actually getting better integration where you need it actually costs money to begin with. You might save a little bit of money in the long term, but it ain't a big game changer for saving money in the system. And of course, this is the one that's probably pertinent to services like yours, where you have got multiple providers in different sectors, is that the evidence also tells that if we want that change to be sustainable, and if you really want to deliver universal, world-leading services, that actually what we need to be ensuring in those design principles is that the different individual organisational and professional agendas of those different organisations that are contributing to your whole system are actually aligned, so that each of the providers, whether you're an NGO, whether you're a state service, whether you're a community service or in primary care, that you feel your net worth of what you're contributing to the whole system. Where an organisation either doesn't own the change or doesn't feel that they're adding any value to the services, then you get dislocated, fragmented services continuing. And finally, you know what you also need, and you'll know this as well as I do, that actually if you can have a policy, you can have a strategy, you can have an action plan. If you haven't got really good, high quality project management sitting behind it and supporting those service champions with some accountability for progress, this was one of the biggest factors for the 60 to 70% failure rate of policies and strategies. So within that action plan, we need to be really clear about who is going to support and who's going to fund that project management. And of course, although I'm not speaking about sexual health services, what I'm really talking about here is, in the tradition of healthcare, is a three-lettered acronym, SBO, stating the bleeding obvious. But what we really, really find difficult is to implement the bleeding obvious. And actually, if I went to any one of you and said, what do we need to do to make sexual health services across New Zealand better coordinated and better for the people that use it, better for the system, you would all have an answer to give. But we seem paralysed a little bit in healthcare compared to some of the other sectors. So I'm going to finish on, I wanted to show you a couple of examples really where I think they've got part of this process right, and because of that they look as though they'll be sustainable, and actually they can articulate and can demonstrate through evidence and outcomes that they're delivering better care for the users of the service, they're delivering a better working environment for the people within the service, and they're delivering better outcomes for their whole system. And that is the one for the Greater Manchester Sexual Health Network, which I guess some of you may be familiar with. I first worked with Greater Manchester and their sexual health services about 12 12 years ago, when they were actually quite fragmented and uncoordinated, and there was lots of unhappiness, from people using the service because they didn't know where to go for what service, between generalists and specialists who weren't really clear about who was doing what, and there was a big protectionist agenda going on too on both sides. And actually they've done a huge amount of work to create a really coherent and sensible network that has brought all those different organisations together. So I would encourage you, if you don't know that Sexual Health Network, just to have a look at some of the work that they've done, because they've done some of it for you. And they've got a really good strategy and action plan that's available on the web. The interesting thing about the Greater Manchester Sexual Health Network, though a lot of it was provider driven, we didn't then have, when they started off 10 years ago, a big national strategy and policy to say this is what we want sexual health services to look like. This was driven from the ground up from providers. And the other one I was going to talk to you about, but I'm conscious of the time, but have a look on the web, because again it's really interesting what they've done, and they've followed the evidence base that I've just quickly summarised for you, is Parkinson Net in Holland. And Parkinson Net was, and if you just Google Parkinson Net, you'll find it. There's a fantastic video on there. Parkinson Net was actually originally driven by a neurologist who recognised that the care of Parkinson's in Holland, there were so many different providers and different professionals, generalists and specialists, contributing to the delivery of care for patients with Parkinson's, but none of it was coordinated. None of it was, the data reporting systems were all in isolated information systems that didn't talk to each other, so it's really difficult to get evidence and outcomes-based data anyway. But actually the providers got themselves together and created a really effective network, which has a single identity, like Greater Manchester, for the service user. You can just go on the web and you quickly can see who delivers Parkinson's services in your area and which one you should go to. It's really, really clear. And actually it's a really good community practice of a network of professionals, so that whether you're working in an NGO or working in a hospital or primary care, actually you are part of that community, and they share data and they share experiences and they share education and they share the training. But there wasn't a Netherlands national strategy to say this is how we want Parkinson's care delivered. It was delivered by people like you who got together and said we need to do something. And that's the website of the Greater Manchester Sexual Health Network, which brings all the sexual health services and what they do and where they deliver from and how you access those services into one coherent website, which when you talk to users of services is what they want. And they've used technology really well. I still think they could do more. They've used technology really well, so it's very easy for someone who wants to access a sexual health service to know which service they need to access and where they can access it, and that might be from a multiple number of points. Thank you.